Welcome to this training for CARE Act implementation. This specific training is meant for volunteer supporters, specifically to explore how they can maintain neutrality in that volunteer supporter role. In other trainings, we've talked about supported decision-making and bias. And in this module, we're going to talk about a strategy to better being able to do that, which is maintaining neutrality. So on the next slide, we can show you an overview of what we're going to be talking about today, discussing the types of relationship between the volunteer supporter and the client, reviewing the importance of the volunteer supporter, regardless of what that relationship is, to support the client self-determination, which is a topic we explored in the supported decision-making module. And then we're going to use a scenario or a case study to explore some of the ways that you can actually do that, because it's easier said than done. So some learning objectives for today's discussion. We hope that this module will increase your ability to explore aspects of personal relationships between the supporter and the client, and then identify some strategies for maintaining neutrality and eliminating personal bias. So those are our learning objectives. I'm going to have our speaker, Barry Jacobs, introduce himself. And Barry, highlight some of the experience in your background in working with families and individuals with serious mental illness and where you're coming from.
Thank you so much, Patricia, and really thank you for joining us today. My name is Barry Jacobs. I'm a clinical psychologist and in the state of Pennsylvania. I've been in the field of behavioral health and medical education for over 30 years. And in that time, I have become something of an expert in families helping individuals deal with chronic and serious illnesses, including serious mental illness. And in my clinical work, I've worked with many families, particularly parents who have a child with schizophrenia, in order to try their best to support that child, often under very difficult circumstances. So I'm very pleased to be here today to talk with you about the volunteer supporter role, and to let you know, number one, I want to thank you for, if you're interested in becoming a volunteer supporter, I want to thank you for that interest. I think the volunteer supporter role is an essential feature of CARE Act proceedings, and I would also say to you, as you heard Patricia allude to, that this is, being a volunteer supporter, especially if you're a family member, is not an easy role to take on. So we're going to talk a little bit about what the challenges are and also what some potential solutions are. Next slide, please. So this is the real challenge here is if you have a relationship with the respondent, if you are a family member or a friend, or even a neighbor or a faith leader, and you now you've been asked to play the role of volunteer supporter by the respondent, and you have agreed to play that role. One of the main challenges is, how do you maintain some level of neutrality and even-handedness so that perhaps the way you might have related to the respondent before doesn't in some way impose itself on you, the way you conduct yourself as a volunteer supporter. Because what we have learned is, to be a volunteer supporter, your primary role is to support the respondent in their decision-making and in their self-determination, rather than you expressing your opinion or providing your guidance. Providing guidance is not the volunteer supporter role. And so the challenge, in essence, is, how can you be someone who helps facilitate this process so that the respondent has the best opportunity to understand the choices being posed to them and to make what they consider to be their best choice, but to do this in a fashion where your previous relationship, your historical relationship with the respondent, doesn't in some way get in the way. So next slide, please. So what I was just referring to is that historical relationship. brings up this issue of bias. So bias is a term that, if you look it up in a dictionary, is defined as a prejudicial attitude for or against someone. The way I think about this is that human beings in general have a tendency that within a very short period of time to form impressions of the people and things around them, and to have not just impressions, but to form opinions about all the things around them. And that ability of human beings to really categorize people in different ways, to distinguish them from one another, that's part of what's given human beings such a strong evolutionary staying power on this planet here. So this is part of the way the human brain works. We look at people, we look at things, we automatically begin to size people up. And especially as we get to know them, we form opinions about them, about who they are, about what they need, about who we are in relation to them. So all of those distinctions, all those opinions that we have, I would put it under the umbrella of bias. And where this could come into to play in a negative way with the CARE Act process is if the way we look at, as a volunteer supporter, the way we look at the respondent is in any way negative. That if we think of that person as incapable of making good decisions, if we think that we know what's best for them, not that they know what's best for them, because maybe in the past we did serve this role as a guide or a decision maker for them. Or if we even believe that we know the respondent so well that we can practically read their mind, and if the respondent is not clearly stating what their preferences and choices are, well, we know them because we know the preferences and choices because we could just intuit them. Well, all those assumptions that we would make about the respondent would be a kind of bias that could, in fact, undermine the CARE Act process. Next slide, please. So really what we were trying to do, and easier said than done, as Patricia said, is to figure out a way to take our previous assumptions, our previous impressions of the respondent, and set them aside. And there are three ways that we're going to discuss doing that: maintaining respect, a type of listening called reflective listening, and really, as I've already mentioned, making a very deliberate effort to distinguish how we have always related to the respondent historically and this new role that we've taken on as a volunteer supporter. Next slide, please. So let's put this in the context of a case example. And if you could unpack this a little bit, Chloe, thank you. So let's come up with a hypothetical case. This is not a real person, but we'll call this middle-aged gentleman, we'll call him Ray. We'll say that he has been diagnosed with schizophrenia for many years, and he also has the diagnoses of alcohol use disorder. And unfortunately, because he's been taking antipsychotic medication for a long time, he has developed type 2 diabetes. He's been in and out of mental health treatment for a long time, and he's currently not in mental health treatment. And by the same token, he's been on and off antipsychotic medicines for a long time and currently not taking those medicines. Recently, he has been showing up at the emergency room at his local hospital with foot pain that's related to his diabetes, and he's currently unhoused and living on the streets. He has developed something of a relationship with a homeless outreach worker who is the person who referred him for CARE Act proceedings. And when explained that he could opt to choose, opt to have a volunteer supporter to assist him, and mind you, not every respondent needs to have a volunteer supporter. It's entirely up to them. But in this case, Ray chooses his older sister, but with some small qualifications. He knows that she loves him, but at the same time, he doesn't want his older sister to tell him what to do. He doesn't want to play the little brother role with her forever. And he mistrusts her husband and his influence on her, and that may have a little bit of a paranoid flavor to it. Next slide, please. So let's keep that example of Ray and his volunteer supporter, the older sister, in mind as we begin talking about eliminating this kind of bias. So we said the first way would be to maintain respect. And the definition of respect is due regard for the feelings, wishes, rights, or traditions of others. I think we all kind of know in our heart of hearts what respect are. We know when people are respecting us, and we also know when they're not respecting us. And generally, when we're not respected, we don't really like that very much, and we may react very negatively. And that is the same is true for respondents. In the context of care, maintaining respect would mean that the older sister is not telling her little brother Ray what to do, but is asking about his choices and preferences, and doing everything she can to make Ray feel that she's heard his preferences and choices and understands them. And she's not going to chime in with her own ideas about how Ray should think about what he should do. And she's not going to pass judgment on his thoughts. She's not going to say, Ray, that's a bad idea. She's not going to say, Ray, don't you know what all the terrible things are going to happen if you make that choice? She accepts Ray's choices and preferences as they are on the basis of whatever beliefs he has. It's a very non-judgmental, non-directive role. She's listening, she's helping clarify, and she's facilitating his expression of his choices and preferences. Next slide, please. The second way that we're going to recommend folks try to stop having bias or assumptions about a respondent is to use what are called reflective listening skills. And imagine a conversation with somebody in which, rather than responding to them with your own opinions, that your main role is to just reflect back to them what it is that they're telling you, so that you're assuring them that you've heard them and understand them. So an example of this would be if Ray said, I don't want to I don't want to take psychotropic meds. I'll listen to the psychiatrist, but I have no interest in taking psychotropic meds. So a reflection would be the older sister saying, I understand, Ray, that even though you're willing to see the psychiatrist, you're not willing to take any kind of antipsychotic medicines. A response would be the sister saying, what do you mean, Ray? That's a bad idea, and giving her own idea. But what we keep saying here is a volunteer supporter doesn't offer their own opinions. So in reflective listening, the volunteer supporter is attentive, they're very patient, and they're reflecting back to the respondent what they've heard, oftentimes paraphrasing what they said. The volunteer supporter can ask clarifying questions, so the older sister can say to Ray, so let me make sure I understand what you're saying. Are you saying that you're willing to hear the psychiatrist's recommendations, but if the psychiatrist recommends medications, you're not going to consider them? Now, and that is said in a way that's hopefully doesn't come across as judgmental, and I would hope Ray would hear it that way. And then the volunteer supporter can also make what are called summative statements. So after Ray expresses all his choices and preferences, the volunteer supporter, the older sister, can say, so Ray, I just want to make sure I understand everything that you're saying. Number one, you're willing to see the psychiatrist. Number two, even though you're willing to see the psychiatrist, you don't want to take medications. Number three, I also hear that you're interested in some support to get some housing resources so that you don't have to be unhoused anymore. And number four, I hear that you're hoping to also see a primary care doctor to talk about your diabetes, but not necessarily to take medicine for the diabetes. Do I understand you correctly? And that summative statement kind of gives back to Ray in a nutshell the things that he has said. And then Ray can say, yes, that's exactly what I have in mind. Or Ray, upon hearing his sister sharing back to him what he said, could say, on second thought, maybe I'm not willing to go see a primary care doctor. I don't even want to have a conversation about my diabetes with a primary care doctor, so I don't want to go. And so the sister would then say again, okay, I understand you don't want to go to a primary care doctor. Sister doesn't express her opinions. Sister is there to facilitate Ray's clarifying what his choices and preferences are. Next slide, please. And the third way we mentioned of trying to eliminate personal bias is by intentionally and deliberately distinguishing between what has been in the past, the historical relationship between a volunteer supporter and a respondent, and what this new relationship is, where the volunteer supporter is playing a very different role. And really what we're trying to do here, and it's not an easy thing to do, but this is what we're hoping, is we want to take the trust that's already been established in the relationship between a respondent and a volunteer supporter, and we want to use that trust so that the volunteer supporter can be helpful, can be facilitative for the respondent, but not have the volunteer supporter react emotionally to whatever the respondent says, or in some way pass judgment on that respondent. So the question here is, how can we harness trust established in a historical relationship while minimizing emotional reactions based on bias? And just again, to distinguish the two, the older sister as a family member may have always had a trusting relationship with Ray. He may have always trusted her as like almost a second mother to him. But the older sister, if she's acting in the role of a family member, has always seen Ray as her little brother, someone who needs guidance, someone who has a very bad disease called schizophrenia, and she is going to try to guide him and provide as much protection for him as she can. And she has a lot of judgments about what's good or not good for him. That's a family role. That's a very important role for the older sister to play. But in her role as the volunteer supporter for Ray, she wants to be that trusted supporter who doesn't tell him what to do, but instead facilitates his decision-making. That the older sister is not being directive and remains largely neutral or non-reactive. Next slide, please. So this is very important for not just the volunteer supporter to be clear in their mind about the role that they're now decided to play, but it's also important that the respondent know that the role is, the relationship is now going to be a little different as they go through the CARE Act process. So the volunteer supporter should be very clear with the respondent that this is not our usual relationship. This is going to be different. I'm playing a very specific role, and the role is to mostly be a listener, to be a clarifier, to make sure that you can get your point across to other people, but to facilitate your expression of your choices and preferences and your decision making. And hopefully, with that conversation at the beginning of this volunteer supporter role, and as they go through the CARE Act process, there's no misunderstanding between the respondent and the volunteer supporter about how they're going to function together to best enable the respondent to be able to express their viewpoint and their decision making. Next slide, please.
So Barry, you've been talking to us about a tool for maintaining that neutrality, which is important for that supporter role, and a major tool for doing that, which is removing your bias. So let's look at a few situations in which remaining neutral while applying those principles of supported decision-making that we've explored in other trainings, where that might be challenging, and some recommendations you might make to maintain neutrality using some of the tools you just described. So this first situation, let's say the respondent asks a sibling, parent, or friend that's playing the role of that supporter role, they actually ask that person to tell them what to do. How could they maintain neutrality in this situation?
I think this is going to come up a lot. I think old habits die hard, and again, using the example of Ray and his older sister, if Ray is accustomed to his older sister to tell him what to do, he may look to her to do the same. But I think, again, if Ray were to do that with the older sister, she would have to remind him, Ray, that's not my job right now. That's not the role that I've been asked to play. My role here is to help you clarify in your mind what you think is best for you, and to help you express that to the court, to the behavioral health agency, or to anybody else that's important in this process. And so the volunteer supporter would not simply decide, okay, I'm going to tell you what to do. Quite the contrary.
So then this next scenario is related. And let's say the respondent doesn't want input or guidance, but the supporter is concerned that they're making a bad decision. And that's in quotes because we talked about in another module to really remove that bias of a bad decision. So Barry, what about this scenario?
Again, I think this is a scenario that's very likely to arise. And so thinking about this in terms of Ray and his older sister, as a family member, the older sister may have the opinion that Ray ought to take his antipsychotic medicine, that he always functions better. He's more the brother that she remembers before his disease when he takes the medicine. However, in this CARE Act process, if Ray decides he's not going to take the medicine and he doesn't want to hear anything about it from his sister, then the sister is really obliged to comply with that. That she shouldn't be making any kind of comment to try to encourage Ray to take medicine. She may, in her heart of hearts, believe that's what's best for him, but that's not her role now as a volunteer supporter. She, as you've said many times, she's trying now to remain neutral, and the decision has to be Ray's.
So let's say Ray's sister has done that, but she's worried she can't tolerate supporting him while he's making what she considers a terrible mistake. What's some advice you would have for Ray's older sister?
I really feel for Ray's older sister in this instance. I mean, she may feel like, how can I help my brother if I'm not telling him what I think he really needs to do? I really do think he needs to take these medicines. If he's not going to take them, and I'm not going to say anything about it, am I complicit in making things worse for him? And she may decide, that she really can't assume this neutral role. That when it comes right down to it, it just makes her feel too uncomfortable. And so, if that's the case, then perhaps she's not the best person to be Ray's volunteer supporter, and that's something that she can raise with the court and ask the court to release her from this duty, and then have the court assist Ray in choosing another volunteer supporter, if in fact he would like another volunteer supporter. But if the sister really can't fulfill the role of volunteer supporter as it's intended, as a neutral facilitative role, then really she should not be Ray's volunteer supporter.
Thanks, Barry, for walking us through those scenarios. I think that helps us see both the challenges of remaining neutral, but how we could try to do that in different scenarios that may arise. And thanks for sharing your thoughts and your background. I know you've worked with a lot of family members and individuals experience serious mental illness, so it's good to have your clinical perspective and advice. On the closing slide, I just wanted to pull up these objectives again as the volunteer supporter. Our goal was that you would have an increased ability to explore relationships, these aspects of personal relationships between the supporter and the client, and then also identify strategies for maintaining neutrality and eliminating personal bias when participating in the CARE Act as a volunteer supporter. Again, if you have questions or you're interested in some of these trainings that we've mentioned, about the volunteer supporter role, supported decision-making, trauma-informed care. You can find those materials on our website at careact.org, and also reach out using that email if you have other questions.